Good morning, everyone. Warm welcome to you on this beautiful Saturday morning. And we have an eminent personality here to address all of us. I'm really delighted to see that leading surgeons from the country. And also, I'm extremely glad to see some young and enthusiastic medical students here. There's no other place to be inspired because we have arguably the best laparoscopic surgeon in the world here with us. So without any further ado, I would like to start the proceedings. For the first session, I would like to invite Dr. K.L. Fernando, Dr. Nishanka Jayawardena, and Dr. Tamanash Chowdhury to come to the stage and take the seats as chairpersons. And also, I would like to welcome Professor Bhavanta Gamage, who is the president of Sri Lanka Association of Minimal Access and Digital Surgeons, to welcome our most eminent personality. Thank you.
Good morning to all of you. We welcome warmly as the Association of Minimal Access Surgeons, Minimal Access and Digital Surgeons of Sri Lanka. All of you are welcome on this Saturday morning. I have the privilege of introducing Dr. C Palanivelu, MS, MCH, DNB, FACS and FRCS EDIN, Chairman, GEM Hospital and Research Center. Dr. Palanivelu was the first to introduce laparoscopic surgery in South Asia, South India. He was instrumental in popularizing this new branch of medicine in India, and he applied laparoscopic technique to all types of surgery, including cancer surgery. He comes from humble background. He completed primary education overcoming great difficulties. But this motivated him to do service to the poor through free medical camps and treating thousands of poor patients. He also trained hundreds of rural surgeons. He revolutionized laparoscopic surgery in the world, making it possible to provide laparoscopic surgery at an affordable cost through his innovations, and has been the essence of his contributions to medicine. He's a great teacher and guiding force to all laparoscopic surgeons, and he's not only a top achiever in the medical field, but also a great social worker, writer, scientist, and a visionary. He innovated over 20 new operative techniques, with which he considered the world's best, and the videos of these procedures are included in the teaching resources of American College of Surgeons, American Gastrointestinal Surgeons University, Royal College of Surgeons of Edinburgh, Korea, Chinese and Japanese universities. He authored many surgical textbooks. For the first time in India medical history, his book got published in various languages: Spanish, Chinese, Korean, etc. He's the first Indian surgeon who was accorded the privilege to operate and teach in various countries, including UK, USA, Hong Kong, and Argentina. Professor Palanivelu is not only gem to India, but also to Sri Lanka. He is the founder president of Association of Minimal Access Surgeons of India. He is one of the best, if not the best, laparoscopic surgeon in the world. He has written many textbooks, as I told you, and we still use his textbooks and read his textbooks in particular techniques before we do surgery. I met Professor Palanivelu in 2005 as a surgical trainee at GEM Hospital, and he was humbled enough to come to the site where the suturing, laparoscopic suturing was demonstrated and taught us how to do laparoscopic suturing. Association of Minimal Access and Digital Surgeons of Sri Lanka has the objective of empowering our young surgeons. And our objective is to optimize laparoscopic and minimal access surgery in Sri Lanka. So this is a golden opportunity for all of us and our junior trainees to get inspired by his tremendous, excellent work. So he has kindly agreed to come to Sri Lanka with, he's a busy man with a lot of working commitments. So he kindly agreed to come these 2 days and be with us. So without further delay, let me invite Professor Palanivelu to take us through his experience in laparoscopic surgery. Over to you, sir.
Okay. Is it possible to change the laptop here? Friends, good morning to all of you. I'm delighted and very happy to be here. And thanks, Professor Bhavanda, for kind words and introducing me to the audience. And thank my friends on the dais, Fernando and Tamanas. Really I'm happy here. This is today's program going to be on different topics. It is for interactive session. I want all of you to be part, nothing else. And this was initiated, this concept was by Bangladesh Surgical Society and 2 years before. And I did not know the way they are made it, and I was so much. And the Intercontinental Hotel, that hall, 1,500 capacity was full registration, and morning to evening went on. And the society president happened to be the Director General of Bangladesh Health, and he was the organizing with the committee. It was so nicely went on. Then I felt it is the best thing to go interact with our own juniors and make it. This program is not going to be I'm sure, last session may be for the practicing surgeons may be useful, that master video session. But before that, 2 topics going to be just casual and talk, interact. Everywhere we go, people always ask, the new technique fine, but there are many people have seen how the few people in the world took it to their own patients started. But America or it is Japan, anywhere, not all surgeons have seen immediately accepted. Many were critics because reason. And the World Congress, when lap chole was shown at that time, and chairperson concluded saying, if I have gallbladder, I will go open, not laparoscopy. Reason, safety not established. If a safety is not established, one cannot clinically practice. Very important is safety of the patients where we operate. That way today, let me have a share just like, and I thank first session is going to be the same question, what made me to accept so much initially start going ahead. When I started laparoscopic surgery in South India at Coimbatore, most of you know, it is, of course, not a small city, but it's not a big city like Chennai, Bombay, or Bangalore, Delhi. It is a small but textile city. Now it is, of course, doing well. There, when I started, everybody said, and even Delhi was not thought of that starting at that stage. And what made you to take interest in doing it? I think Tamanas knows he only initiated the program along with this Bangladesh in Dhaka. And we had the same programs in India, multiple places, going around the country to initiate the youngsters, particularly trainees, postgraduates, young surgeons. And 2 things you can be. One can be Xerox paper or you can be a writer. Xerox is whatever comes goes, no. That means anything somebody has done, copying a technique is one way of doing it. And something you look at as a science, look at how to adapt a better way to our own community, that is other way it is. That's why this is second topic is going to be innovations, what I contributed my most to the procedure. That is my journey. Now the first topic is going to be. Even this slide was made by Bangladeshi surgeons that I continue the same here. And I think Bhavanda introduced me to your crowd, no? They're saying that I'm from a remote place and I wanted to make it to this. And gastroenterology surgery was not a specialty at that stage when I did after my MS. But I want to be a gastroenterology surgeon because during my MS I saw a lot of cancer patients, particularly esophagus and pancreas, not properly attended. So I want to specialize. No MCH available that time. And fortunately, it came later. I could finish MCH, continue my practice. Most of the in India, people were farmers or laborers, and they have to get back to their routine work faster. I'm a farmer, so I knew the difficulties of village people, how to get it done. So that's why when I saw that keyhole surgery, oh, this is the best way that I can do something to our community to get back faster. That was my interest initially. And when I did the first few gallbladders, as literature all said, it is so important. No? Next day, even not next day, the same day the patient walking without Ryle's tube, without drainage tube, going to toilet, coming back, and this has so much gave me something to do. And looking at that, another things also, as long as no incision, then wound gapping may not be there and infection is not there. Long term also, we don't see incisional hernia and additions and pain. That was the initially. But suddenly if anyone do, a particularly open surgery you are doing it, suddenly given a laparoscopic surgery, see, what is the difference making you interest in doing it? 10 to 15 times magnification, no? That structure. That too, if you take camera closer, you can see the minute thread like it is a bigger way. 2 millimeter duct can be say in the 10, 20, 15 millimeters like. Second thing, you can rotate the angle. You can't head putting it at different angle to see. But here, laparoscope, 30-degree scope, you can rotate and see angle view. And surgery is done very minute way, bloodless manner. And that made me interest, okay, let us do. Not only that time it was discussed only lab chole initially. Then step by step, many centers in the world were going. But I took it my own way how to go about. As a GI surgeon and been doing all major surgeries, including Whipple, esophagus, my own. So I could modify each procedure into minimally invasive way. From starts with the 93, I did a CA rectum, cancer rectum, IPR. And by 98, I could do Whipple. By the time entire procedures, we could do laparoscopic. Wherever I go, people ask, sir, what procedure, sir? Everything you're doing, all procedure. And you're doing, no, I have not done all. Then you look at what procedure not done, sir? Cesarean not done. No? That I always say that. No, that is where, no. Of course, cesarean also possible. I used to say, hand assisted, put one hand can be there in the Hull's procedure. You can do it, take it out. But next day, paper will say, cranky guy doing something, you know. That we don't want that name. You know. And also patients used to come, they're saying that, very important is, sir, I was afraid of a scar, sir. Now scar, keloid tendency, whoever has got, it is not there. Young people, appendix, gallbladder coming, young girls, they are very much accepting it. Before, if you do open, that is, that young age is very difficult. So that way you do. And second thing, a small complication like collection inside. Suppose you do appendix, there may be some collection. Even a gallbladder, there will be. But reendoscopy, laparoscopy, you can drain out well without laparotomy. That all possible here. That is very important. Then I took it first to gallbladder. I was happy doing it. Then I decided to move out. Then I went to America for a 30 days tour. It was a very costly tour. No? That time I did not have money. I had to borrow from people. I had to go through. And then technology started showing a very much improving it. Initially, single chip camera, poor light source, like eating in a AC restaurant like, no? Slowly then you are able to get clarity of tissues much more than open. Now you look at HD, then went to 3D for 4K, now 8K has come, and then robotic also has come. Now different way it has gone. And the cameraman, laparoscopic fellow moving the camera, but robotic you put it in the camera yourself, so you have a stable vision, you can do anything. So the interest going because of the technology also helping us. And everybody used to say keyhole is a limited vision, better open and see line. Now later, lot of technology technique improve. You can't get that vision exposure like a laparoscope and open. You can't get it open like this. And all types of finer instruments came, and that was very important here. And not only that, open surgery, very difficult to identify is it a cancer tissues or it is lymphatics or not. Here, you can, ICG is there to find out cancer spread. There are two instruments now say this is a cancer tissue, this is non-cancerous. And multiple small tumors in the pancreas, particularly neuroendocrine, very difficult to see in any way, but you can see in ICG with the laparoscopic robotic. And minute tubular structure, sometimes may not endometriosis to ureter or this, very difficult to identify. But here, if you use ICG, it will tell you where it is. That is very, very important. See, small one video, I'm gynecology, they were doing it. And see, dissection, they are not known where the ureter. So now see, that is the ureter, it is under the tissue. So nicely is known. That is very important. Suppose vessels identify, you give ICG, it immediately will be coming across that way. Now look at that. So here also doing lymphadenectomy, you may not know that, and see you can look at lymphatic tissues remaining there or not. So technology helping us to make it our own surgery much perfect way there. And advantages, what are the advantages in laparoscopic? Even a narrow area, you can go and see that area, work out, and remote possible. And laparoscopic abdominal wall helps you holding the instrument. Only advantage, disadvantage is moving opposite direction, but we don't feel by experience. So a tremor is reduced in laparoscope, and robotic totally it is filtered. So no instrument shaking or this one. And clarity is so much enhanced, spatial vision possible. So robotic surgery now it is very popularly coming. So I was happy doing laparoscope. Now I'm happy sitting in a robotic doing it, because there are added advantages like perfect 3D vision, stable platform, and trembling. And suturing also in selected places makes it more easier. See here, small video clipping I'm shown in a Whipple's operation. And look at, I'm doing a coccus maneuver. And many of surgeons have seen Whipple's, or even any surgery, some of the identified tissues. See, look at IVC here, I'm going under these. See, taking the head of pancreas, and going see IVC here, and you can see under the head, you can so well see here. See, now I'm at the level of the SMA and celiac axis, which I'm using is a harmonic scalpel. So far, see, I have not used a gas piece, no blood, and clean field. And see, look at any doubtful lymph nodes, we'll take it for sampling before proceeding it. So under the head we are working, which is not possible to see in open. We have to rotate, hold the pancreas, squeeze the pancreas and doing it. And a small video here just for appendix because some trainees are here. And then look at, this is a reduced port, wherever you wanted to avoid a scar, you can doing it. Smaller way of holding the gallbladder traction through intergastric space, which is my own technique when I'm doing Whipple. And this was done many years before. So you can look at only one 5 mm instrument and take it out and putting it through umbilicus, take it. At the end, I'm sorry, this is a very poor quality video. This where one stitch, again, no scar seen, and this is what something like. This all possible. Single incisions also done. And new sciences have started coming, which was not there before. When we are MS doing it, I did not talk about bariatric surgery or it is a metabolic syndrome. And see, that became now becoming a more popular across the world because our lifestyle, diet, everything is towards metabolic syndrome. Diabetic type 2 is going up, cancer is going, liver problem is up, infertility is again more. These are the things we need more important. Organ transplantation was not there and become a very good specialty. And hernia, those days, if you operate, people don't come for surgery because of high recurrence rate. 10% recurrence, fear. And not only that, after surgery, we'll tell them 2 to 3 months can't do hard work, they have to take rest. That again the problem. Now, hernia operation can be done in a daycare basis. And you can do it such a way that you can guarantee the patient no recurrence. And the patient can do routine work next day. So that kind of new revolution happened in hernia surgery, and even abdominal reconstruction, which I will be talking later next session, I will tell you that. So minimally invasive anal surgery and surgical oncology cancer. So I went to Spain in 2017. I was asked to do a D2 gastrectomy during their conference. I did, and the patient got admitted at 1 o'clock, and I operated at 4. And by the time I reached Coimbatore, not even 48 hours, email coming from the patient, thank you very much, doctor, operating me, I'm doing fine. See, D2 gastrectomy, patient goes home in 48 hours, and imagine that kind of no blood transfusion, no pain, patient recover faster. Even at the end of a gastrectomy, no Rayleigh tube, and no drainage tube. And it is like a way, if you do right hemicolectomy or other surgeries, next day patient can be discharged. Hysterectomy patient can be discharged next day. So even some of the patient, if you are ready, patient educated, many gynecologists, morning operating, evening they discharge home. So it became even a cancer surgery became a daycare-like, and very important things today look at. And I will talk to you later. And this small, see, mediastinal surgery is something is very difficult. So you look at aortic arch, left neurological nerve, as though we are sitting in the mediastinum like possible, which is you can't even imagine in a open surgery. So laparoscopic robotic is the way today, and cure rate has been enhanced. And if you don't open abdomen, if you don't give blood transfusion, immune is undisturbed. And there, that recurrence is less, long-term survival is better, and that also added factor, and that is why I will be talking later then. So that is way, that's why. And today, cancer, I already talked about, a changing scenario in the world over. How much a patient, these are two, one splenectomy, another is acute pseudocyst pancreas. I did it in Bombay, took the patient morning flight, operated in the afternoon during the conference. Not even 24 hours next day, the patient were walking in the airport. Parsaradi, we all went to the patient, took photograph in the year 2001. So, see, and everybody surprised. The boy walking, climbing up the flight and came to Chennai, Coimbatore, everybody started talking as a story like. So that way, what my aim first, faster recovery, that happening it is successful and much more important, added advantages also. And even a cirrhosis liver, we always call, morbidity more, mortality very high, difficult to operate, even a gallbladder surgery. Now, and Whipple's or liver resection or any other surgeries, minimal invasive, do it, patient, you can do it. In fact, in Pune, I was doing a conference, that time I was asked to robotic Whipple, it was cirrhotic liver, many surgeons are afraid to touch. I said, this has been routinely doing it, no issues. I showed them, the patient got discharged on the 6th day. So these were, that way it is a minimal invasive can help. This patient was refused surgery Whipple because quoting his age, only 79. That 79 is not age, nowadays. But he was, the people refused. When I did it a surgery Whipple, and he came for review, but he has to go wheelchair because of employer. And he gave me 2 lakhs rupees extra for poor people service, also giving a Vivekananda book. This girl from Delhi came operated at the age of 14 for robotic Whipple, and this patient, after 3 years, she stood in the Delhi state rank holder, and she came to me, took a photograph in the hotel during the conference. So these are things. So a superior outcome and reconstruction or identifying tissues, and more important, and staplers, new stapling has come, reconstruction. Nowadays, we don't talk about leak. Those days, leak, any surgeries, very important. No? Leak makes the problem. Now, reconstruction can be done very well with the minimal invasive way, using a technology, a suturing or this, and without leak. So finally, to say, minimal invasive standard of care, surgeon's performance increasing it, less complication, faster recovery, acceptance of the patients is very good. So that's why when any technology comes, surgeon keep open mind. Whatever comes is changing. It is always changing towards the higher quality of surgeries or a different way. So that's the reason that I took interest in laparoscopic. By day something is coming. Something interesting new coming. So we always keep in mind to learn. You cannot say, I'm very busy, I don't have time to learn something like. Every surgeon will be busy, but changing towards a higher goal must be the more important. And that way, I think, thank you very much and for this. And I want speakers, you talk about something like whatever that is more important. This is interactive. You also can ask anything here. We can have discussion. Should I start? I can be there. I can stand there. Only mic only can speak.
Honestly, good morning to everybody. Honestly, I am a blessed person to be associated with a person like Dr. C Palanivelu. I always thank God that I born in a time when I have seen a person like Palanivelu. Why I am talking this? And truly, and I feel the same kind of feeling a lot of our colleagues have. We cannot assess by seeing a person just by meeting person. If we look his journey, if we look his thinking process, if we analyze his activity, they can realize what can be a person. And to me, honestly, sir, I don't want to say in front of you, he's a genius to whom I meet in my lifetime. And I just quote from one sentence from his own words from his book, that's a published GART. I don't want to be rich. Sir is saying, I am not interested in richness. Any person can become rich by opportunity. Skill is difficult. It's God's gift, which is chiseled by hard work. This is quote from his own book. And from these very sentence, we can understand what Sir is. I just why this program was basically Society of Surgeons of Bangladesh interested to host a program for Palanivelu sir at Bangladesh. They are interested, just sir should come and deliver some lectures in their meeting. So we have decided, I asked sir said, okay, you fix up a date. Then I discussed with Parthasarathi what can be done. They decided for 4 hours program. Then we divide into 4 components. Why I became a surgeon, how I became a surgeon, and what is the innovations which can be done by Dr. Palanivelu sir, and what is the future of laparoscopy and minimal access surgery. Like that way, we discussed and divided the components with Parthasarathi. And then we put it to sir, said, okay, whatever way you decide. Then that Surgical Society of Bangladesh, they took a sponsorship of a company, Bacon company. And I know some of their persons of that company. So they agreed to sponsor their program. And honestly, I am telling you, I was there in that program, and Bishrup also there. And there is almost 2,000 surgeons in one of the biggest hotel of Dhaka. The meeting was there. It started at morning. It goes up to even 5 o'clock. And the company, they have one, I'm saying the other side of the program. There's a huge response from and even they don't want to finish the program even after 5 o'clock. It started going like anything. So the company, they had a cefuroxime component in their market, Gerotrail, that drug street I remember. They launched it. And means they just revamped that product on that meeting. And that time their selling of that product was 9 crores in their market. And 1 year after, I asked the same company person, what happened? You sponsored so much for this program. He said, sir, now we became 36 crore in market in 1 year we grow. So I'm telling this story, and always I have not shared to you, sir. Sir, you became one of the biggest marketing ambassador of that company. Sir, I shared I thought in that way, the people joined in that meeting not only by listening and taking some lunch and go back, they are both way committed. And then I check with the people who attend the meeting, what their change in their surgical practice. In other side, some of our friends say, after sir's meeting, we have think in a different way. Some of the people not doing hernia because of their hesitation that we can't do. But they are very good doing gallbladder for 5-6 years, but they cannot transform themselves into do hernia. So their experience that after SIR's meeting, we thought differently, we put some more effort, we go some videos, some other teaching programs, and we have started change ourselves to become a laparoscopic hernia surgeon. So that is the transformation of their thinking process. I hope this meeting will definitely, every time I join this meeting a day with master, after that in Amasi we take up this program that we will do in our different cities. And we have done almost 5-6 programs in our different parts. And I feel that today's meeting will change our thinking process, that what exactly as a surgeon, what more we can do and what better can be our life. Thank you very much for your patient hearing. Thank you very much.
Yes.
Good morning, everybody. I think you are meeting one of the surgical giant in the world. And what he said was most of the people were inspired by his talk and his few videos. Their setup is slightly different from us because most of the hospitals belongs to them. But you all have a different challenge. You all are working in the government hospitals, but it's up to you to start this. The way you start in individual, I can see a lot of young surgeons seated in front, and it's up to you to get this message, what he gives. You should be motivated and inspired what he has done, and he has gone and proved himself he is the best, even in a country like USA. To go and do the Whipples in a country like USA, it's not easy at all. But he changed their mind to do that. So that kind of a personality we are associating now, and it's absolutely pleasure to meet this master of surgery in our part of Asia. So you get the message. You all should be motivated to go and do whatever surgery. You know, sometimes people are working in the private hospitals and the government hospital. It doesn't matter where you work. It doesn't matter whether you get money or not. Never go behind money. If you are a good surgeon, money comes behind you. I can vouch for that in my experience. Well, in 1992, how I started, what difficulties I had, how much difficult to go and teach other people to motivate do this, how many people criticize this technology. They don't remove the gallbladder completely. Those are some people, telling the patients. But I get the feedback, but I never looked. I just kept my head down, never criticized anybody, continued my journey, and in a way I am a successful surgeon in my country. So same way, each individual, whether you are working 4 years in a peripheral hospital, it's up to you to develop it. If the government hospital is not preparing, you ask some entrepreneur to sort of start a hospital, and that's the way to do it. You leave 4 years and another guy comes and actually continues. So that's the way to do it. I think, we are, Sri Lanka has gone through a very, very bad, difficult financial difficulties, but never worry about that. We always come back. All what I know is our people are very, very resilient. We have gone through 30 years of war. Have we become Ethiopia? No. So what is the reason? Our population is a very resilient people. They can be absorbed. So the message is you have to imitate Professor Palanivelu's what he has done in his life each individual can be, emulate that. And you put that into your practice. So what we have done in Bangladesh is one of the lessons. There we go. 2,000 people, and they all bought instruments. And the company is now very, very rich. They sponsored that huge meeting. That's the way to do it. I think you all got the message. That is that this today meeting is all about. Thank you very much.
I think we got to know Dr. Palanivelu as an expert in laparoscopic surgery, probably of the whole world. I came to know him maybe about 7, 8 years ago. And at that time, he was very well established. I think there were some qualities to take from him as a surgical trainee and a surgeon. You should study his life story as well as his laparoscopy. That shows how a man can achieve the highest status in the world with perseverance and humbleness, and also the skill, how you can develop. And he has shown that, because he has not, excuse me, sir, he has not been born with the silver spoon in his mouth. And he has, with his own, with some help of his close ones, he has come to this standard. And he has shown the whole world that you have nothing that you can't achieve if you have the will and the skill and the intelligence. Other extremely, one quality which I appreciate in me is the sharing of knowledge. From the very early stages when he became a established surgeon, he has written so many books, and some of his books have become the Bible of laparoscopic surgery, but not only in India, but in the whole world. And he has developed so many new methods, and he has not been stingy about sharing it with others. That is the main quality. And I think that has improved your skill as well, sir, by teaching. And he has been so keen to come and teach. I think that is one of the very high qualities I see in him. And so is our Dr. K.L. Fernando, whom I was a medical student when he came and started his first laparoscopic surgery. He was criticized so much. People were talking about port-site malignant deposits. When he was talking about, those days there were no bags, so people used to deliver the gallbladder from the umbilicus, and they were talking about port-site deposits in the umbilicus. And so rare. In this country, unlike India and Bangladesh, the gallbladder CA is not that common. And port-site deposits are so rare. But people are talking about it, just to criticize, just to put down. But these people are giants, actually. And I am very happy, and I'm so proud to share the table with them. And I thank you again, sir, for coming us and enlightening the young crowd with your capabilities and skills. Thank you very much.
Would have seen their experience. I think Fernando, when it started 92, the criticism all will be there. Anything, if you take good or bad, even do good thing, there will be some criticism there. But ethical value must be there in every walk of life and surgical practice. As long as it is okay, no issues. I thank you very much, all of you, for sharing your own experience. And Tamanas, Fernando, everything, very nice way. And this is a message to all. Thank you very much. Bhavanda, we can move to the next session. And I usually call the speakers, I used to give some compliment to them to say thanks. No? Whatever we do, unless until without support, we cannot. That's what, whatever we today, because of students, teachers, everybody support. And I thought my Guts lifestyle book would have been released. I wanted to compliment, but I will be giving it to you in person later, during these occasions. I've written autobiography in the name of Guts. I will give it to that later.
Thank you very much, Dr. Tamanas Chowdhury, Dr. K.L. Fernando, and Dr. Nishanka Jayawardena. To move on to the next session, I would like to invite the chairpersons to the head table, please. Dr. C.J. Varghese, President of Association of Minimal Access Surgeons of India, and Professor Bhavanta Gamage, President of Sri Lanka Association of Minimal Access and Digital Surgeons, and Dr. Dhammika Rasnayaka, who is one of the very senior minimal access thoracic surgeons in our country.
Connected. Can you? Yeah, it has come. And this topic is going to be my journey over these years since 91 till now. But mostly it is the first 10 years what we have done, contributed. And it is a journey, is not just like I'm going to talk. How each procedure I modified accordingly to make it suitable. That's why it is innovations. And any procedure come, and safety must be always improving every time to attempt it. If you do 10 cases, if you do 100 cases, by the time the quality must improve. Second thing, my aim was to make it simple so that every general surgeons can adapt the procedure in clinical practice. Second. Third is, it should be a cost effective. Just high tech, high cost does not mean that it's going to reach the middle. Any science reaches a majority of the people, we cannot consider a success. That means cost effectiveness is very important, third. And fourth one is, we cannot keep it our own way. Individual surgeons can do better to society, but it cannot be called science. And majority of science should practice and the community should get it. So that means, if it available training must be given to the surgeons, even in a remote area. That was my main aim in the beginning itself. And second thing that I already told in the previous one, new technique is coming up, new procedure on technology science like metabolic surgery, abdominal wall reconstruction, all new coming up. So that means we have to involve making a new procedure, developing it. Sometimes when I do, as Fernando said, and criticism, not only criticism, in fact, because I was doing lab Whipple, and my center was de-recognized for 2 years for this. No, he's doing it. No. Reason, everybody said, he's doing it fine, it's better than open, he's doing it, what harm? No, other people also will tempted to do, and it is a problem, general surgeon doing it, temptation. It is, but finally now, everyone asking me to do live surgery, everybody has come. So it takes time to do it. So these are the 5 aim was with me from the beginning when I started practice. That is very important. So all you know, in the lab Kohli, first when we introduced, only simple gallbladder used to do it, not even difficult gallbladder. Acute gangrenous, all step by step came. Those days, even now, same practice we do it. What you do, we put a clips or loop for the cystic duct, control it. That is the way you do lap choline. And everybody used to do it. The same thing, we are also practicing it. But suturing, intracarpal suturing was not in the beginning of the laparoscopic surgery. Because needles are, conventional needles cannot go into the abdominal trocar, they can't use it, that is why. And in 92, my physician asked me, Palani, I have a case, 32 years old, who is cirrhotic liver and recurrent attack of acute cholestasis, and he has underwent portal hypertension surgery 5 years before. Can you do laparoscopy surgery? That's what he asked me that day. I said, let me try 50-50. If it is possible, I will continue. Otherwise, we have to do open. If they agree, I will do it. Yes, Palani, you do whatever you like. No, I did. I could dissect up to, it was a very dense additions, everything. I have to infundibulum. Beyond portal cavernoma, I cannot go beyond. Then what, if I do what, if I open, what I am going to do it? Again the same thing, I am going to divide the infundibulum, suturing it. Subtotal cholecystectomy is a difficult situation, acceptable open. So why not I do in laparoscope? What is lacking behind was, what was lacking is a sutures. So mine sort of, okay, take a grasper fundus, that is one, took a virus needle, Vicryl 20, widened it, put it in the scope and suturing it. The patient went home second day happily. So that gave me confidence. Any surgery needs suturing, put a Vicryl or PDS inside and doing it. You know? See, that is a time that Western countries, they described a ski needle that can go to the trocar for suturing. And they used to struggle so much. You know, ski needle, I don't know how many anyone practice or not. It is that not easy to doing it. That is a time, there was a conference in Luxembourg. I went for the meeting. I presented the many procedures like this. Subtotal, GJ, all procedures. Every procedure suturing, no? Always conventionally sutures, put it suturing like. Even GJ, I showed a continuous GJ 2-layer. So whole conference started talking, oh, Indian is showing something, is suturing so good. And everybody started talking, saying that simple, faster, looks like open suturing. They named it as a Palanivelu's suturing tech method, or they call Indian method. No? That is the way it is. And that was the trend setting for laparoscopic suturing. And that company started making curved needles for laparoscopic suturing. See, simple one. I had nothing to do. You need not do any lab research for this purpose. No? That mindset went in a word and put it. I started suturing it here like this. See, this is a gallbladder. I divided it. No loop you can't put it. You can't put it clip. So this is the best way to suture it. The patient can go home and the next day, provided if you want to keep a day or two for antibiotic, you can keep nothing else. No? So this is a kind of things that I started in 92 and was helping me. And 94 went to Kyoto World Congress. I was showing all types, Indian experience, all types of gallbladder that even John Hunter in charity session, he was so surprised. He invited again to the stage, Professor, you described how you do it subtotal. We are not doing, practicing it. Then immediately I was even invited to Sages giving a talk. See, that type of cirrhosis liver in India is very common. And Western countries, that time alcoholic cirrhosis, our cirrhosis is nutritional cirrhosis, and we can do it. I sent a paper to World Congress in Philadelphia, presented my paper on cirrhosis liver, laparoscopic management problem solution was the best paper whole conference. And that paper got published. I could not give that time. I published later on, and Jack said it got published. I did not keep quiet. I'm happy about laparoscopic gallbladder, but still I have to do something more. What I did, okay, subtotal, modified cholecystectomy, difficult gallbladder, how to manage. I defined various types. I presented in the World Congress, Rome, and again that paper won the World Best Paper Award. And this Montori and the secretary giving it. I was fortunate that judges were John Hunter, Professor Udwadia also, as a ELSA president was there. So happy, and that it is. So the same conference, I showed many videos, and diaphragmatic hernia, choledochal cyst, and hernia different types, achalasia cardia, and all of them are innovations at time. Why I'm going to say one by one. A lady, 1996, that 23 years old lady came. She was pregnant at that time, 6 months. And patient came to hospital, oliguria, breathlessness. Then diagnosis made acute gastric valvulus and the entire contents of transverse colon, spleen, everything in the left chest, diaphragmatic hernia. So what I thought, if I do a 6 months open, pregnancy maybe get affected, why not attempt laparoscopic, The attempted, I did not have a composite mesh. I have to use a regular polypropylene mesh after bringing the spleen, everything here. And that, this is a lady I operated, and she delivered a female baby. This is a female baby, grown, and she got married. And 5 years before, now he has got a 4 years boy, So wherever program I go to Europe, that side, whole family will come take a photograph going. So this is happiness. The another interesting is we go to hernia. Hernia is 92, nobody thought of doing it. France and America, only few surgeons doing it. I'll tell their name later. In Asia, no one has done it. But I was very keen to do hernia. And the reason being, one boy came asking me, sir, you are doing something new technique without opening. Can you do hernia, my hernia, that technique? That boy asked me. I did it. Next day, after 1 week, patient came to my clinic with a happy mood, saying, sir, I have 3 testes, sir, I have 3 testes. Many of you know what happened, no? That time the technique described was, in the literature, putting a mesh into the canal sac, closure the internal ring, plucking technique. That mesh which I put it in the canal moved down to the root of scrotum, making a testis like. The boy did not complain. He was happy about it, having a third test. Then I told the boy, this is what happened. And I explained, put a 1 centimeter nick incision root, I removed the mesh. Okay. And for 3 years, the patient did not have a hernia, did not come. But it was pricking me something I have not done a proper technique. So 92, I went to America, 30 days tour. It was a costly tour for me. So I decided to do something. Johnson Company told me, sir, if you have, this is a prototype hernia stapler. If you have this, you can do laparoscopic hernia. So $3,300 US. When I can't buy, no. I have to told my friend to buy and give me. When the American surgeons came to know, who is that cranky from India spending that money to buy, they considered me as a cranky, I did not know that crankiness, I realized later, After coming back, I did it 50 cases. That time, all of you know, hernia, we use a 11 by 7 centimeters mesh, smaller size mesh, not like 15 or whatever now. So my fear of extrusion of the hernia, particularly direct hernia, may be there. But I know suturing, So I use suture the anterior wall with the sutures. Cooper's ligament, I used the hernia stapler. After 54 recurrence, all the 4 recurrence were at the hernia stapler. Then I realized I'm a cranky, what they told. Stopped that day using hernia stapler, started fixing the suture to Cooper ligament, no recurrence. Then after that, we started using a large size mesh, and you know how much it can be done well. No, I have not used any mechanical stapler, tackers or not, throughout my life. Suturing, very effective, cost effective, very good. That's the way it is. And there again, 2 types of hernia repair has been described initially. One is TAP, another is TEP. The TAP, McCarnan taught me, because I went to Cincinnati and underwent 3 days animal training. And McCarnan, we all know, he's a pioneer in a TAP technique. He taught me how to do. But I'm not convinced of the technique. So I did a TAP only in the beginning, came back. But there was some difficulties, particularly low place umbilicus, scar, fold, something like. Then what I did, instead of keeping camera in the umbilicus, I used to place a camera in the epigastric. Then I could do a wide dissection. I could no fold problem, no scar problem. Entire pelvis can be seen. And I can excise the sac. I can suture this seroma. I can reduce it. So that helped me TAP. For 3 years, I could do about 700 cases, 92 to 95, and this. So these were wider dissection, Xing, very effective. But by the time you can turn the camera anywhere side, you can doing it, wider exposure, 2-hand technique, you can do well without any trouble, that is way. And you can even suture like this very comfortably, no problem here. And this I presented in a Singapore conference, and that time when I showed Koreans, Japanese, everybody was so happy to see. And even pediatric internal pili tract, I described first, published in the article also. That's why when I got a hernia book published, first wrote it, Korean Society took it as a textbook, they published in Korean language. And now, 4th edition is came and almost completed now. We are this year going for a 5th edition. This is 4th edition. If you see, including each step, we describe a step-by-step description in the book. And now, 95, okay, everybody talking TEP, no, McCarnan talk, then why not I move towards a TEP? And Duloc, a French surgeon, is a very great surgeon. By looking at, I wanted TEP. But by the time my knowledge so much had developed, my own way, I described my own technique, putting the trocar between the rectus muscle and the post-rectus sheath through umbilicus. And I have a wide space dissection, extrafacial suture, two-hand technique. It is called PTEP. And that time, McCarnan, I told midline trocars, difficult to do large hernias. So what, this is my own technique, you all know. Large, any size of hernia, we can do it without any problem. I showed live surgery in many, and including Rome, and I was invited to Argentina to demonstrate how I do a hernia repair that time. But mine is a tap to tap, but the McCarnan is a E-tap, but it is a low place trocar. And see, this is my technique I am showing, subumbilical, rectus sheath. You can see the trocar going between the rectus muscle and the post-rectus sheath, retrorectus. Then subsequently I take 2 working trocars either side. Then I can work out like taking the sac, and even however big sac, irreducible hernia, no problem. That's why conversion mine is almost nil. I could do almost any type of hernia except strangulation. So this is one. So Western people did not know how I do a P-type. No, what they were describing it. And looking at McCarnan, there are a lot of difficulties, what I felt like this. And George Dees is who described E-type, and he placed the trocar in the retrorectus higher level, and he called it as E-type for groin hernia, and that is technique came. And compared to these two, both we can do either George Dees E-type technique or P-type for groin, but entire groin can be dissected my own. Now this is the best way to do. Any young surgeons, anybody can learn, and bilateral or single or a difficult hernia can do it. Okay, now I'll move towards the ventral hernia. Ventral hernia is a very common problem in Asia, particularly India and Sri Lanka. And LeBlanc described IPOM, place a mesh with a tachus all around, a double row, whatever maybe, And I did not have the composite mesh. That time I could not get it from company. I waited for a few years, and 98 I described my own technique. And I did few like IPOM. The ladies were, hernia is okay, but I asked you ladies, how is the working capacity? But none of the ladies ready to work, because Indian ladies or Sri Lankan or Asian ladies are flabby abdomen after 1 or 2 deliveries, and we do a mesh inside, abdomen hanging down, functionally is not improved. Then I felt how to do it, take it up. Then I described defect closure, then the mesh. Bringing the rectus muscle midline, place a mesh. And that is called IPOM plus. So the IPOM plus, whoever talking, it is the origin from Coimbatore. This is our own technique. See, this is a technique which I am using it. And see, look at those days, I used to do any type of suture. See, it is ethylene loop. And like what we use in open suture, I am using it here. And see, it can be sutured well, and completely bring it out, can go behind. And then tying it, put a mesh inside, composite mesh, and that works very well. And again, another problem here, this is the technique I described in live surgeries, Coimbatore, many places. I wrote textbook there, also described technique. And not only that, even American college surgeons, they invited me to write this chapter, how to IPOM plus. I wrote a text come operative manual there. And I presented this in American Society, Boston, and 720 cases. Recurrence rate was very low compared with them. Seroma very less. Functionally is better. And it was so well appreciated. I published this in a hernia journal. And subsequently today, IPOM Plus has become the standard of care throughout the world. And the another problem is in our ladies, I saw, divarication recti, very common. Even I think the gents also now going to develop divarication recti, very common. Belly is very commonly seen due to lack of exercise or eating rice so much. So divarication is another problem for which if you don't correct it, recurrence will be there. And I seen one of my patient also when recurrent was. Then I described technique called folding technique, plication. You can see that anything you multiple plication pull it, when it is folded together, the rectus muscle come to the midline. So it is we published after doing a series of cases, and by which abdominal grip increases functionally better. I published this journal first time in the world, hernia journal, how to correct the diastasis. Today, if any hernia we say robotic or laparoscopic, whoever does IPOM plus or divarication plication, and this is both a technique we invented and published, then they were following it up. Now I'm showing a lady with 10 to almost more than 10 centimeters divarication recti. Look at. This lady complained and sir, everybody calls me, are you pregnant? Are you pregnant? Because abdominal wall hanging. Do something, sir. So there we take it, going from one side to other side, multiple sutures like, so workshop I'm demonstrating that you can appreciate. This is a very V-lock sutures, barred sutures, very good. We can do it very well. Anybody can practice well. So after that, place a mesh like this, and did a CT at the time of surgery, before surgery, after 1 week, after 6 months, no single recurrence, and the patients are very happy working it. So this is another one our own innovations here. And subsequently, the mesh inside the abdomen, whatever composite mesh, some kind of additions possible, no? So avoid constipation, then when additions, and I didn't do the first time TAR, and Western Beliaski did it first. But the technique origin is ETEP, what I placed initially, the same technique only they adapted. And ETEP, what we did 2 types of compared IPOM plus ETEP, and ETEP large series also we published in hernia journal. And see, this is the largest series we published. And this is comparing IPOM plus ETEP. I'm in favor of ETEP, but IPOM also is good as long as one can practice well. That is way. No? See, this is ETEP. Now, Excel, it is a telescopic technique. Trocar going between the rectus muscle and the post-rectus sheath, you can appreciate there. So, I'll come back. See, after going back, so between the rectus, post-rectus sheath and the rectus muscle, and making a space, and we put a working trocars, camera and this. See, now you can see triangulation made it. This is post-rectus sheath on the left. Now we are going behind the linea alba and the falcium ligament. You can see just hook enough. Nothing you need any energy sources more. No? Now this is right rectus sheath. Now you can appreciate. And between the rectus. Now going down, taking down. See, look at, this is a technique now, and now become a standard of technique for all. See, now inside also you can go abdomen, bowel additions can do it, momentum is there, you can do it. Now the right side, left side of the rectus is taken up. We go down to the pubic symphysis and this. Now you can see there is a irreducible bowel. Momentum. You can see the previous sutures. This is a bowel. Now the right rectus, we take down, you can appreciate here, and both rectus fall down. Now this is a post rectus, this is a V-lock suture, where it can be easily learned, anyone. Now today MRC is offering training programs in this ETEP regularly here. See, you can suture it, it is absorbable one. Now we'll go anterior, non-absorbable suture. You can see again barred suture. This is a V-lock. Here, hernial defect as well as the divarication we correct together. Previous sutures all you can appreciate. Now you can see place a regular mesh, no composite, regular polypropylene mesh, and this patient can leave the hospital next day, and this is where it can be done well. This is. Then again, very big hernia like this, if they wanted to have hernia, you can't put it the contents inside, no. See now, you can appreciate so much bowel, reduced capacity. Now you can appreciate, I'm doing a external component separation. This is my own technique. And they described a different way. I'm described here, you can appreciate scarpa fascia and external oblique aponeurosis. Widely you can. By if properly done, 10 centimeters each side you can get it, and abdominal capacity will become much more. So now I am going between the opening the anteractus sheath, see, identifying linea semilunaris, go to lateral view. Now you can appreciate, I can take it a wider space dissection. Because I am going between scarpa fascia and here, no seroma, no need for any drainage tube. And if you go like Western people, between the rectus, external oblique and the internal oblique, seroma is very common. See, now you can see, this is I demonstrated live, in fact, last June at Coimbatore during the conference, the same video I am showing it here. So, this is where the hernia, a revolution happened, hernia today, and one can be done very fast recovery, less recurrence, back to. Then colidocal cyst come, pediatric one done by Japanese first, adult I did it the world first, and I presented video in Sages, it was the best video. And in fact, Blomkart book, they quoted my article as a first initial series that minimal invasive can be done well. And this, see, this is a 3 years old baby, such a big colidocal cyst. Taking down the colon here. And at one stage, we have to decompress. You can see the proximal duct, hepatic duct here. And decompressing it. And now you can see dividing at the hepatic duct and coming down. You can see such a big, again coming down, and that bile duct will be, CBD will be very, very small. You can put a clip or you can put a, that's. Now we take it hepatic jejunostomy and see, we can suture it. Because of magnification, suturing can be done well. So this is another procedure where we don't do open at all now, and unless there is a carcinoma, and we can do everything well. So another procedure is very important, is which I had done is achalasia cardia. And first time when I did it at Coimbatore and presented in Goa, ISG, Indian Society of Gastroenterology, furious, no, this cannot be done laparoscope, it should be done balloon. No, that is what's, and then I have to explain them. The boy whom first I did it, 3 times dilated by people, failed, not able to relieve the dysphagia. Then engineering college student not going to college now. After my LS, now he is going to college, it can be done. Then 2 issues they raised. Reflux may be more, mucosal injury can be there if not properly trained. And there what I did, see, I have described a scissor, my own. See, if you use the scissor, one can do with a bloodless manner. And this patient has actually 5 times dilated, and muscle you can say hypertrophed so much. And with this one can do without mucosal injury safely. Because see, you can see muscle so much hypertrophed. Okay. Now mucosa, so intact now, injury is there. Again, we do a wrap to prevent reflux. That also can be done well. And this lady, and when she was 3rd month pregnancy, came to me with her husband. And that time I explained to wait for a couple of months, then come for surgery, and asked them to undergo dilatation, balloon dilatation that time. But 5th month, the husband brought her saying, "Sir, you operate, I don't want the baby, because the lady is not eating, and the baby will be undernourished. I don't want undernourished baby, sir. You operate, anything happens to baby, I accept it." I operated her LS, and she continued pregnancy, delivered a baby, nice baby, after birth celebration. So this is the world first pregnant LS that we did it, and published the article as well. But unfortunately, her husband died in electrical shock after a year. That is was pity. And mega esophagus, we can treat laparoscopic. I done the large series, 2000 here itself. We published that's this one. So here again, achalasia cardiac grade 4, you have to resect esophagectomy. It can be done neck anastomosis, it can be IV levis, intrathoracic anastomosis, all possible. Even a carcinoma, one of the cases, I could do transient esophageectomy. Sometimes it goes into shortening, that also it can be done lengthening procedures. And so now you can appreciate mediastinum, you can see up to neck you can get dissected. See, now you can go see like this. See, you can go dissect. Even a carcinoma, even a partial lymphadenum can be done, we can do it. Actually, this was done a live demonstration, that is possible. And the fundoplication GERD is a very common procedure. The only question is, regular fundoplication everybody will accept, but giant hiatus hernia, if it is there, mesh has to be placed. Mesh is always can get a road into the esophagus sphere. There I described a suturing technique, I will show later because it is not in this video. See, this type of large one, if it comes, you can take it out. And crura is always two component muscle, inner and outer. I have a suturing I will show later because it is outside. And that can be done double breasting. And technique, we continue suturing, no need to a mesh. And in the last 5 years we are doing it, we are very happy about the results. And I was not keen to do bariatric surgery in the beginning. One ENT surgeon came to me from Kerala, asked me to do a bariatric gastric bypass. And I told him, I have not done before. If you agree, I will do it. It happened to be the first case. He says, yes, sir, I know that you may not have done. I was surprised. He knows that I have not done, asking me doing it. Then he told, no, sir, my brother is a surgeon in Bangalore. He has seen you how gastrectomy that you do laparoscopic live in front of thousands of surgeons. So for you, this is simple, sir. I brought internet page, publications. He gave me 56 pages. Go through this and operate, sir. So much. And then I did it first one. Then this boy came 210 kg. And so first surgery, second surgery, and now he married here. Now I'm looking little fattier than this boy. See, this boy got married, and after that, I was the chief guest for the marriage also. And he got that, his father got a grandson. No? So you want to remember our family. So name, somebody has to name, no? Put a Palanivelu, they can't call De Palanivelu, no? That is irrespective. No? So they put Pravin Raj, my son name, and they continue such a, this one, happiness. So again, lifetime, many things we don't know. While doing a bariatric surgery, we understand that type 2 diabetes completely resolves. And that duodenogenital bypass, which we did the first time in the world, and in fact, Pravin got, my son got the Best of Sages Award at San Diego in America. And that is the one technique which he described, very nice. And now it has become. So this health minister at that time, he got hernia operation. He inaugurated my department also, bariatric. And this was the South India first recognized first center for this one. And another interesting is, this lady gave liver to her husband. The surgery, it is donor, liver transplantation. This surgery was done previous day of Valentine, and we don't look at Valentine, no, these youngsters, okay. I did the surgery 10 o'clock over. Next day morning, I went to the ICU. I was so surprised. Every doctor, staff talking. Sir, this lady 6 o'clock went to her husband's room, next room only, no? Chatting for 1 hour. Found out they are lovers before marriage. And Valentine's Day, she want to greet her husband. See, such a wonderful gift one can give. I don't think anything more than the liver one can give to her husband, like, no? So very nice, appreciating that, This was the world and India first laparoscopic liver donor operation done. So now this is, I'm going to show videos later, I will talk about. Today, when I did the cancer in the beginning, everybody said, many centers in the world did the cancer, but some quarter always will be against, no cancer, you can't do it. I showed transcital hysterectomy at Adair Cancer Hospital, and transcital, no, live. Everybody says 2000 when I'm showing a whole cancer surgeon, first time saying it was surprised. And not only that, and people have not seen those things. That's why now today it is local recurrence less, improved survival, quality better, and today Japan government has given insurance. Any surgery done initially 2010 they gave for laparoscopic Whipple, laparoscopic esophageectomy, all. Now last 3 years they have given even a robotic cancer operation. They consider it's a higher cure rate and a very good quality, and government in Japanese always when recognized that means something is more. So that's why we have a lot of difficulties there, but we have to understand any cancer, if it is operable by minimal invasive, kindly operate, that cure rate is very high. And but I will briefly how touch 2 surgeries I had developed, then we'll wind up this session. And 98, I did the world first Whipple operation at Coimbatore. And 2 years before Michel Gagnère in America said, I tried few cases, complication more, I stopped doing it. It is one hand assisted. That made me irritated, no, he was not done. He's an extraordinary surgeon, but that was not done well. So I came and did first time. I took a Sunday, and I did not know how long it was going to take. Sunday is a free day, no phone call, not like mobile, no, even a regular phone disturbing, no. So no OP, nothing. We started surgery 8 o'clock. I took 11 hours to finishing it, in between 15 minutes for snacks. And next day they saw the patient was comfortable, cheerful. I'm very happy. Then subsequently, next day surgery it took 8 hours. And within few cases, I could reduce the time around 5 to 6 hours time. Now, I've done more than 40 live operations, Whipple operation, different countries and in India as well. And average about 4 to 4.5 hours, straightforward cases. And that everybody agrees that time is a very standard time for open also, and it is. This is the first lab, This guy got married at 3rd month. He had a jaundice, went to Madurai. He was diagnosed as a head of pancreatic carcinoma, periambular carcinoma. And they told, with surgery or without surgery, lifetime is around 6 months. How much, mentally disturbed. And they also told, we don't do a Whipple operation, either go to Chennai or Coimbatore. Then he came to me. I did a Whipple, that is the first baby, birthday they came to me. After the 2, you can see, this is the 2008, when I was invited to America for Olympic surgery competition. At that time, I took photograph, and there, 9 surgeons were selected for final round. Whipple for me, and liver resection, breast guy, and like stomach, Japanese like. And finally, me and French surgeon came equal. That they, in order not to have a tie, they say made a reduced 0.5 to me. They give me silver, and the other guy, French prize guy, got the gold. First time in the Olympic surgery competition. So this is such a complex operation possible. And when I present the video, Sages, it was the best video. And Buchler, German surgeon, great pancreatic surgeon. If you go to his center, it is a factory of pancreatic surgery. And sometimes 2 or 3 Whipples they do in a day. That's a center. And he used to talk against Whipple. Then what we made, we invited him to Coimbatore. He was doing one screen open. I was doing a laparoscopic Whipple, another screen. And finally he said in his lecture, today accept that the best is laparoscopic. And I agree, Palanivelu is the way. But another problem is the question came, robotic laparoscopic, that everybody used to say, robotic is better. No? This Cian Tan is a great robotic surgeon in Hong Kong. I'm also faculty to this. Regularly I used to go there. You can see the world pioneers all here, including Leroy Giulianotti. And he did a robotic Whipple one screen. I did a laparoscopic Whipple another screen. I finished before him came out. And then he told, I thought I have Benz Palanivelu coming by bicycle. That cycle reached before me. No use with the Benz. 2014 the comment was. But 2015, I went to All India Institute. There was a cardiac surgery was going on. My friend suddenly gave me, sir, you repair the valve, sir. Intra-cardiac surgery, valve repair, he asked me to do it. I have not touched robo beforehand. Then I tried. I suturing it. Then I found, oh, this is something, technology also very essential. It is something that fascinated me. Then I came back, I got Robo, Da Vinci. 2016, I started at Coimbatore. And of course, I do a lab Whipple, robotic Whipple continuously. I'm happy about Robo now. The technology has improved so well. But whatever I earned, only I earned for a Da Vinci. We lost few crores to my hospital. Too costly, and it's not that benefit. But of course, technology is also we keep it. The best, ICT world, RCT did world first hours, and we published in the British Journal of Surgery, and that was quoted as the best article there. And not only that, I was asked to give a guidelines and how to proceed, make it popular across the world. You see, pioneers all the world over came to Coimbatore, and it has got published a Coimbatore Subject Statement in Surgical Oncology. I was so happy that title was coined by Japanese people. And these are the ports. I will show video later. I will show the Robo. Some people may be there. That video I may not be. So I will show. See, this is a robotic harmonic. Left hand, you can see the bipolar. And I'm doing Caucus maneuver. You can see. I showed laparoscopic beforehand, I can see the similar way. Don't look at this speed we operate. I'm pushing it double speed. Of course, robotic you can do faster and by training only. Now you can see the left gastric, left renal vein. I'm working with the nodes along the SM way and celiac axis. So that's possible like. The another procedure world over we made it popular is esophageectomy. It is known after my name. And Duluc used to come to Coimbatore. They have seen me how I do a prone approach esophageectomy. I invited to his center. I showed a live. Subsequently, I was invited to UK. I had not been UK before, no trained. I did not have a FRCS. And I was, General Medical Council gave me a special privilege to come and operate there. I did the esophageectomy and prone. Subsequently, every year I used to go to UK. I did Guildford, Leeds, and everywhere the live surgeries. And here, Japanese surgeon, I did a live at Cochin and prone esophageectomy. Japanese surgeons were there to see how we do it. Till that time, they were not. And he went and told Japanese surgeon, it can be done with the thoracoscopic prone approach very well, like a open what they do. Then I was invited to Hong Kong to demonstrate esophageectomy during Asia-Pacific Congress live. And that day, there were more than 1,500 surgeons from China, Taiwan, Korea. Completely, this prone approach became well appreciated because every step what I showed a new. 2-lung anesthesia, single pneumoendotracheal tube, comfortably you can operate, wide mediastinum, and no lung retraction. So everything was positive way that appreciated. Then, till the time I not published article, and Japanese surgeon, if you don't publish, we cannot do it. Then I published 130 case first series. Then Japanese invited me to Kyoto to run a training program, both Whipple as well as the prone esophageectomy both. And since that year, every year Japanese used to call me, go. Every year we are also improving Whipple and esophageectomy in a different way. And this has become the standard of operation throughout now. And this esophageectomy won almost all continent the best video awards. I will show you later the video. This is another innovation. If you do gastrectomy and esophageectomy together, and you can appreciate here, substernal placement of contude. I did it first and presented the World Congress in 2003 at Mexico. You can see here, I'm going up to the neck. The finger will be coming from the neck dissection. Then we pass the plastic tube and Ryle's tube. I always do a right colon with ileum and the right side colon. Now you can appreciate. It is a very good technique and replacement here. And in the neck you can make a situs anastomosis, very nice way. So this is where. Okay, these are all passed through. I'll show video later. And another nose word I coined because I removed the specimen through vagina or through anus. And I coined a word and published article named nose. Nose nothing but natural RFI specimen extraction. So that is, and you can avoid abdominal incision. That is very important, and that's why now young people also developing carcinoma colon and distal pancreatic tumors, and anywhere you can do natural RFIs is a good way. And last innovation is, this is pyrotic lymphadenectomy. If you do it, and very difficult to get the retro approach. Now you can look at, this is rubber traction technique, my own way of putting it. It to the abdominal wall, it will come out like this, simple way. Then 3 or 4 on either side. Now like that. See, now we look at aorta, IVC lying lateral to the mesentery. Now you can appreciate, I'm just dissecting it. No instrument is retracting the bowel. The rubber band giving a traction. Rubber band is a dynamic traction sense. As you dissect, it pulls the intestine away. See? Now you can see the IVC. Now you can see the here. This is a common iliac. Now we take the nodes in between the aorta IVC, in front of this, you can take it out. Very nicely can be dissected. I demonstrated this live during gynae operation. Gynecologists, instead of talking about the nodes, they all started talking about the rubber band only. Sir, to teach, they used to call me to show how the rubber band you are placing. Now you can see here, this is left renal vein, aorta, and here. The maximum clearance one can do by this. Even if you want to do for any carcinoma rectum, and previously the recurrence comes, you can operate up to hiatus. You can do complete pyrotic lymphadenectomy, you can do it well. Okay. Single incision is again very popular, very good technique. I don't know why these surgeons not adapted much, and single in here. Distal pancreas, total colectomy, anti-resection, continuously I'm presenting in SAGES. Every year these videos were winning awards. First time done in the world. And this is the books which you all mentioned. And there was a World Congress at Paris. They wanted to appreciate the maximum contributors. The 2 surgeons, they want to do it. I did not know how they selected. They invited me to give the honor. Me and John Hunter got it. And this Mario, president of the European Society, that they announced, we in order to avoid bias, he sent opinion poll across the European surgeons whom you consider the maximum contributor, without anybody's name. And at the end, my opinion poll was in favor of me and John Hunter, and they gave me the awards during their conference. That delighted Europeans all recognizing that somebody from India doing it. I'm very happy for that. Now today, and it is becoming a very much popular training, upper GI, colorectal, bariatric, minimal invasive surgery like. In fact, we run post fellowship programs at my own GEM hospital. Now MRC is conducting a MRS program for surgeons. And in fact, we are going a colorectal, MRS, we are going to have a upper GI, we are going to hernia. Last month we had a hernia. This is a mastery in minimal access surgery, bracket specialty. This is not just like giving everybody, it is assessing them properly, taking a level, next level, like a super specialty. That is one we are doing MRC. Today I'm very happy. We have a televersity through which I think MRC Lenses program going on every month, one live surgery, you can do it. The quality all will be happy. I think Parsari here, he has established televersity transmission, so good quality. We have a smart center for training programs. Thank you very much and for opportunity sharing. And I invite our chairperson to give a comment, and anybody, delegates also can ask questions. Not to Govanda.
Thank you very much for that inspiring talk, and how you develop the new techniques and how you were criticized sometimes, and then the world decided to accept your techniques. It's very inspiring to all young surgeons and young students here. So it is reiterating, and how we have reiterated that the quality and your ability to operate is not comparable, and you are no doubt, we have no doubt in our mind, you are the best laparoscopic surgeon in the world, and we are so fortunate to have you here with us. And I think Dr. Vagish will have something to comment, and because we are running short of time also, I think we will discuss this matter over the next few hours. Over to you, Dr. Vagish.
Thank you, Dr. Bhavanda. And first, let me thank Dr. Bhavanda, the president of Slum Arts, for inviting all of us for the joint academic program with Amasi and Slum Arts. In fact, no, ever since Slum Arts is formed, we were there for the inception of that. And then the joint programs are going on in a very good way, so that I think that members of the both associations and even others are getting benefited. And the message of the laparoscopic surgery is going too far, reaching to more and more people. And coming to the program with Palanivelu sir has said that it started all in Bangladesh. Later on, then it was thought that Amasi should take it up and do this program all over, in India and outside, so that the youngsters, especially the youngsters, will be benefited out of this, because this talk. I have attended most of such programs in India, and as a president of Amasi, and I found out that the youngsters, not only youngsters, even seniors, they are really motivated after this, to go for, to achieve further in their career and profession. And if you look at sir's career, it started with a very humble beginning. It's all there in the book sir has written. And I can share that sir was in the beginning the labor class, and that time they migrated to Malaysia. And life was very difficult. Sir is discussing. Okay, sir is going through that. And from that level, sir has come to a level like, it's been recognized all over the world. In the House of Parliament in UK and all other countries has been said. It's a big achievement. So the message is that any one of you can, achieve whatever you want in the life. And it's not that, you have all our problems, but if you put the problems in front of you and say that because of that we can't move forward, I think that is something wrong. I think we need to correct it. That is the message what we have to take from this, and we can go forward. And we also, myself also, being, closely associated, being a student of, sir, in the sense, we all learned the laparoscopy and went forward through this, seeing sir's programs, videos, and all those, teaching materials. We started laparoscopic surgery in a couple of years later after sir started in Kerala. And at that point of time, it was, only few people were doing, and it was not very popular at all. There was, as Fernando sir has said, there was a lot of obstacles to the laparoscopic surgery when it came in. In fact, at that time, all the surgical, the scenario was dominated by the professors from the teaching hospital, and they were totally against this new modality of the treatment. So even you can't speak in a meeting like this, and you can't present a paper on laparoscopic surgery. Immediately you will be criticized. And the whole thing that initially it was accepted was a laparoscopic cholecystectomy. Anything more than that, if you say that if you are doing an appendix with a laparoscope, yes, then you are heavily criticized, because we can do with a very small incision. Then why do you want to go for a laparoscope? But at that point of time, I think there was one person to lead. I think it was Palanivelu sir in the front. And because of that, this laparoscopy got the present status in India, and it has been developed from its infancy to the advanced stage. I think sir has contributed a lot. I think we all know that. And definitely, I think that has helped. And the message is, again, I would say that not only to the youngsters, but to the seniors also, to make changes whatever required. I said that sir is not adamant. Like, sir was totally against, I believe, against robotic surgery in the beginning. And to a certain extent, and afterwards sir changed. And when sir changed, sir became a master of the robotic surgery within no time. So I think that we need not stick on to the ideas or the decisions what you have in the life. always. We can change according to the circumstances. It's for a good cause. And definitely at the program, at the end of this program, you will realize that definitely you will be taking the message, what I said earlier, and it will be helpful in your career and profession. Thank you very much.
Thank you very much for your inspiring lecture, and congratulations on your great success. And sir, that behind your huge success, there may be some kind of even small failures. For developing surgeons, what is the advice you can give how to manage effectively that your failures and that your failing points? Can you just give us a good advice about that?
The very important is now everybody used to come, they say, after a few gallbladders, sir, I know gallbladder, I want to do more advanced, casual, they mention. So they take it lighter way. That is not, should not be. That's why I showed particularly gallbladder when I'm showing hernia when I showed. It is something is continuously changing and improving technique, one must be. So the basic procedure, one should be very confident before going. And we should not aim to do a number of surgeries more. It is not that aim. And you should have a passion working in a particular procedure, making it. That's why I always take it in front of patient, take a folded hand, look at. Try to do the best to the particular individual rather than, oh, be happy, I've done 100 gallbladder, I've done. The conference I used to see people say, one fellow will say 500, another guy will do 600. Next conference, 6 months, you can say 1,000. Like, they're proud to call numbers. No, number is not essential. More important is how technically you can doing it. Complication possible, but complication pathologically related, fine. Ignorance of a technique and doing it, something you don't know, you can't do it. You should not do it. By doing it, a patient suffers, it is a mistake. And see, one of the kind of workshops, it's going on in place, surgeon doing gallbladder, bleeding, and in fact, even auditorium hall people say, why not to open at that stage? And he did not open. Finally, at that level, he says, when the BP started dropping, then he says, can you call somebody to come take over doing open? Because that guy has not done proper open surgery, but he is doing laparoscopic surgery. That is wrong, no? He must be competent in that procedure. If one is a master, if I do a Whipple or esophagus, if necessary to open, I should open and doing it. Otherwise, I should not. And any simple surgery or not. That way, that certain principles one. And one need not do every procedure. That is not that. If you go to Japan, Taiwan, Korea, organ-based specialty is their one. And that's why they master in that particular thing they do. 5 years they work on a particular organ, they become this. Same attitude must be there. If a general surgeon laparoscopic, do only basic, don't try to do something which you can't do. But there are specialists in the colorectal group, upper GI, HPB, they can. But practice, slowly go. Don't jump, want to do, all of a sudden want to do this. That is, I think.
Thank you, sir.
Thank you very much.
Anyone here want to ask any question? Yeah, please. Mic, get the mic to him. I am purposely coming this. Is not that teaching and giving to you. It is to have an interaction with you. What is your vision, that what is you wanted to have. And that is very important. Doing sometimes life surgeries, most often technical discuss going back. I have not discussed with it directly. That's what I wanted to your yes, please.
So that regarding new innovations. So when you start doing, you won't be able to perform everything at one new technique at once. So how do you plan stage by stage? Or so when you are doing a first case, do you plan for a second case? I should have improved in this manner. Or how do you do that?
Yeah.
So how long roughly you take to move to the next step?
Yeah, it is not long. It does not need but be this long that it is not necessary. Your competency, suppose we are doing gallbladder, you are doing appendix, and the instrumentation you learn very well, fine. When you move to a next procedure, for example, if you take it a hernia, then understanding of the anatomy, understanding of this technique, how it has been evolved and open, that you have to incorporate doing it, because already you know, technically you know, then you can adapt it. That's why any procedure, suppose you do hernia, say, that's why I told hernia what I made mistakes and how to changing it. So one self is more important. Okay, one can learn proper way 10 cases. Some surgeons we do 100 also still again because they are looking at number, they don't improve their passion. Every surgery, next surgery when you do, it must be better than that. If you have done 100 cases, 101 must be better than the 100. That experience should help you. That way go. One procedure doing, okay, I've done so many open, why not I do? Yes, fine. They get it, take a simple cases do first, then you can step by step more pathological cases. For example, pupils, when guidelines we make it, if you look at, it is Coimbatore guidelines we publish in the journal, there periampullary, smaller tumors, and without cirrhosis, without ERC pancreatitis. Like this, we give a guideline. So that way, you choose your simple cases, do competent improve, then you go to next level cases. That's a step-by-step learning is self, you cannot, each surgeon, there are surgeons, experienced surgeons, there are new beginning, postgraduate suddenly enter practice, they cannot be equal. So it is, we cannot make a guidelines or do. The sages said 50 gallbladder open surgery, the people going for laparoscopic. In South India, one of the meeting I laughed and said, I don't know how many professors have done 50 gallbladders, very rare those days. Now it is very common. So, you do a diagnostic lab, additional is doing it, appendix anywhere in the world common, you do appendix, and you learn that part, then you need not have a 50 gallbladder doing it, take simple gallbladder, do well, then go acute gallbladder, simple, again go like a step by step. That's why I told that. That is why he has to go also. Yes, Fernando? Yeah. Mike.
In 1991 or 92, I think the Americans had a huge surgical meeting, and somebody was demonstrating, and all those guys who came saw one and went and did it. And they brought a very, very bad name for laparoscopic cholecystectomy with a very high bile duct injuries. That actually is not the case. I think you have to have a training. Some sort of animal tissue you can actually use, and that's the reason we have actually established this, our skill center. You can try that before you apply to the patients. So I think, I'm sure behind him he must have done that. He didn't say that, but these are, I think, your proper training. With some tissue you do your anastomosis, then you apply to the patient. So, otherwise you are making, like in, they call American cowboy surgeons. So that's a bad thing what they did. So after that everything was actually standardized, proper training. You have to do so many cases, attend to so many workshops, then you have the license to go and practice. Thank you.
For example, one of these conference, me and my friends were sitting in Mexico. One guy came, presented his robotic cholecystectomy. Then my friend was telling, Palani, look at this guy, is going to have a complication. Then he will say, I'm going to ask question about complication. After presentation, he asked, how many cases you had a problem with this injury? He said, this case. How did you manage? Then he says, he didn't manage. He has to call somebody doing it because he is not a qualified surgery experience there. And because robotic, he says easier to do, he attempting it. That is not correct. Maybe robotic, laparoscopic. And if you have a problem, if you can't manage, that means you are unqualified for that particular procedure doing it. But there are certain policy like at Korea, gastric surgeon only do gastric fine. They will go up to hiatus, anything intra-abdominal anastomosis they will do. If it has to go to thoracic anastomosis, they hand over to thoracic surgeon doing it. Similar thoracic surgeon. That is a specialty. But complication related to that particular procedure, he must be experienced. Initially, Americans and many people did not projected their own complication. Then later, slowly it all came out. And they used to ask me, how many cases you train each procedure to go. Truly telling, I cannot undergo training with somebody else to come and doing it because we are engines, we are going in the front. So every procedure, we have to do first time doing it. So I cannot look at somebody how. But colorectal surgery, Europeans and Koreans were doing very well. So I learned certain things from them. But, and any other procedure, it is. But I was in the beginning, I spent $1,000 for lab coli program, and after coming back, okay, every weekend I should do endo trainer, suturing, doctor nurse, this all. Mentally only thought I had never done even one day endo trainer session. But everything is step by step, learn the patient, not one day, over years. Started 91 gallbladder, by 98 people, this step by step. If I can do well partial gastrectomy for leiomyoma, then I can do a next gastrectomy cancer. Step by GG. Like everyone, step by step, I know what I'm doing it. And that's why, that is because I'm a MCH GI surgeon, I know every possible. Liver resection or Whipple operation, open I do, so many I've done, I can do manage. But just like beginners should not make it up. They can work in a team, HPV team, for a couple of years. They learn fully then before independently going outside. Yes. Yes, yes. Mike, a little louder. Yeah.
So whenever there is a technique, do you have your auditing team to look into your outcome and follow up things?
Which, can you repeat?
So if you are introducing, doing a new technique, sir, is there any auditing team that following you and the outcomes and things on?
There is no team to judge me. I'm the judge for me, mine. If I can't do better than what I do in open, I will not do it. If I do a 10 surgeries laparoscopic, if a 10th one I can't improve a technique better than, I will not do it. Because mine is a private sector, small hospital, that to visiting, that Whipple operation I did in a hospital which I am not owned that hospital. I was going a visiting surgeon, 2-3 hospital, operating it, so I can have a quality assessment or anything possible. So consciousness is making it. What I do, I look at that patient's mind, I am doing it. I won't do good for the patient, that's why that procedure I am doing it. Then when I am doing it for that good, I will not, quality compromise will not be there. And procedure which I can't do better than my open, I will not do it. That's why I made it my policy in the beginning. But of course, I make it after 10, 15, making it simpler. Other surgeons, all, everybody can practice well. That is why. So I want to run a science, so then I have to be good quality for myself. Every surgeon should also same good quality, train them accordingly into going. But nowadays, hereafter, robotic surgery has come, laparoscopic complex surgery. Corporate practice is much more than individual practice. Corporate should have a quality assessment. And Tata Memorial Hospital, Cancer Hospital, Bombay, they have a system. Every year they have 2 days or 4 days, they have a review. And suppose we are doing HPB, my team has to project each procedure, what last 1 year done. And the reviewers not from that hospital, they will come with different visiting process like, they will comment on. Why not this? Why are the guidelines? Like a discussion, then they change next year. That is a very important way to progress. Self-assessment of the institution more important. That is it. But I'm in the beginning, no one can be. Teachers, professors, everybody. I'm lucky that most 99 laparoscopic surgeons were general surgeons with MS, including FRCS MS. Very few, I could not say any other name, with a GI specialty my own. So that's why I know my own background. I could, any question asked, I can answer accordingly. That is the way it is. That's why Japanese, Koreans become very successful because they are specialists in that particular field. They're doing it. Still, I'm doing all round. No, I should not do. I should encourage youngsters to. That's why my hospital, they can do only upper GI, and there are colorectal group only colorectal like. But hernia is a common everybody can do because trained like this we are. Yeah.
In the 1990s, I think we are masters in open surgery. As a registrars, and we were trained, and we have done so many open gallbladders. Most of the open surgery was actually, we are masters. I'm sure you are in that category.
That background helped.
That is the time the laparoscopy came, and we actually just convert into laparoscopic. Now you are in a different ball game altogether. You have not seen too many open surgery. That experience is not there. You are going to start laparoscopic from the beginning. So we have two different category of skills involved in yours and our time. So that is the reason the training period is so important.
Yeah.
So your answer, what is very, very relevant, that auditing, that is a must. Whatever you are doing, you got to audit yourself, then you have to prove yourself that you are good, then you publish your papers. I think these are two different eras.
Yeah, this is initially when came laparoscopic when I started up our own GI, and they used to ask me, say, gynae, why not you do? I'm not a practitioner to make money. I'm a GI surgeon, want to develop science. I didn't do. Later, slowly, the urologists and because they were also not doing laparoscopy, so they wanted to learn. Then they came. Kerala Society Urologists used to conduct meeting at Coimbatore for laparoscopic workshop in urology. So I'm forced to learn and teach. So pediatric surgery, urologists, gynecology, of course, Bombay and Kerala, they started doing before me. But some of the procedure with child. Later that I used to teach everybody only for teaching purpose. And that now everybody started doing it. I am confined to my own field. So that is why we are. In the beginning, I said, our open experience, commitment, want to do something, that all put together, we made initiatives. That's why from Delhi, Hemal, many of the surgeons, urologists come to Delhi, everywhere come to Coimbatore doing it. And in fact, one of the conference I was addressed to give 1 hour talk, how urology, laparoscopic surgery is evolved, and show the technique, how you do it. After my talk, videos, everything, German surgeon who were chairing it got offended. Started shouting it because of you people see, general surgeons started doing urology, where we all to go? Then I have to tell, no, I'm not practicing. Because these people asked me to train, I'm doing the training. That's what it is. Yeah, you want to comment? You want anything comment?
And that's the same thing that I want to tell you as well. Now, the question related to him that I want to ask you, we have the similar problem. Now when we go to, our trainees are starting with laparoscopic surgery because our surgeons are now doing laparoscopic surgery. So now we have to evolve a system to train them in open surgery. Now bailing them out, now you and I, if we have face a problem, we will open and finish it off, which the confidence of our trainees are lacking. I just want to ask you, what is your comment? What are you doing in India to get over this problem of, now if a surgeon doesn't know the open surgery, he's not going to do. So as you correctly said, that surgeon operating until it bleed and until the blood pressure lost, he called another surgeon to come and open. Same thing that we are going to face in the near future, or we are facing now.
Yeah.
So how to get over this? What are you doing in India?
Yeah, this is the issues. When our batch like Fernando or we are all, we open is a strong background for us to do it, no problem. And in between people coming off, they would have done the some procedure open, some procedure you cannot. If you nowadays any gallbladder, even ordinary fellows will not go for open, no. So if you want to do open gallbladder surgery experience, you can't get it. That is not possible. But more important is, and if you want to know a laparotomy training, then you have to go to animal only training, come back. That is also not going to help you when you have a problem doing it. You must be expert in that one, no? That's why. But like a pilot, and the training system in pilot, and very important for surgery as well. That means hereafter trainees must work intensively for example, if it is a fresh, at least 2-3 years, properly in a particular field, learn competency, assessment, then they come and practice, it is okay. So training like a pilot, that intensive training is more important before. And competency assessment is also more important to do that part of it is very important. But reverse way, pilots, if you ask, are you know bicycling, if you know car driving, if you know not possible, need not be. The training that, like a pilot training, intensive training is the most important we can. But otherwise, certain things very difficult to judge. That is far not possible. Now still open operation is being done. For example, cancer in India is still larger section done in open way only. So that's why you tell them, and I train oncology surgeons also, but general surgeons can go and work there, learn, open that part and come back. And they can't learn open gallbladder, open appendix, but they can open other surgeries, major surgery by assisting. They can develop something like reconstruction, suturing, stapling. They can learn open. But after maybe another 10 years, 15 years, difficult. Now today, Korea, Japan, open they cannot learn because most surgeries they went into. And India and Sri Lanka still in between open surgery is going very much. They can put into rotational. For example, DNB candidate, when I was doing MCH, gastroenterology, I was 15 days Vellore, 15 days Bombay, 15 days Delhi, we went in, different surgeon, different way, and seeing it, that time only open, not laparoscope. But still, it helped us a lot of way to learn. Indication, selection, doing it. That confidence more important that, and even at DNB training in now, they should be rotated different centers going it. And we know which center is doing it, which are the procedure. So 15 days, 20 days exposure. More than that, now available videos in YouTube and the surgeons and our own library, MRC Lens, all plenty of videos. Repeatedly see, learn, and improve your skill. That makes you difference rather than those days open surgeon, all by doing and learn. It took time. Now your material resources are plenty now available. You can learn. The simulation is available now, training it for robotic. Da Vinci they have and CMR they have. And that simulation you can practice, learn. But in learning more in animals, you can do it. In some centers, cadaver available. So wherever opportunity is there to learn more and doing it, that is way. But right now we cannot put it this way only can be doing it. But after some time, society is going to evolve. Now, our Salamats and MRC can work out to do how our surgeons need. We're not like America or Europe. We can in America, if you go, cadavers are plenty available. India, you can't get it. And that is the way it is now we have to look at. Fine.
One more thing to add about your question. I don't think that going back to open surgery is answer. Because now we train all our general surgeons to do basic laparoscopic surgery. Now people who want to do highly specialized surgery, there are tertiary centers. If you want to go and do colorectal, you go to work with Professor Bhavante or someone is doing it, and you train there. So it's not everybody going to do Whipples and you got the message. Our system is so good now. We advanced to such a level of training. All the trainees must do a chole lap appendix. If you want to do hernia, you go to a center and learn that, not to go back to a sort of open here again. So that's get the message, because otherwise our trainees get a different. So don't think our training is bad. Our training is high, very, very high training, surgical training in Sri Lanka. Whenever you guys go and look abroad, they tell you, buggers are very good, man. You'll have, Paka surgeons.
Very
nice. That is the thing. Yeah. So don't put yourself down. Learn. Go to the tertiary centers. Learn it. Don't go back to open.
Now we have materials plenty, written books or those days, no books, no. Each surgeon doing a different way. And we can't say which is the best technique or not, unless until we, evidence-based also, sometimes helpful, sometimes not possible. You can't do RCT for certain diseases. That is all not possible. But now, many of the surgeons used to call me, sir, I have this problem, what to do this. A lot of way people express they need manuals for guidance. So then only made me to write operative manuals, text come atlas, all wrote. Now it is plenty, like many of the authors have got it, plenty videos now available. And one should spend time to learn the best, should not shortcut. Okay, I know. That, even today, if a procedure, if I do any procedure, if whatever all the experience calculated, I should do little better. Different way, then only I am a learner. Otherwise, difficult. If I feel that I know everything, then finish. I will not progress. That is very important. And seeing some of the junior surgeons may be operating, seeing it, smaller tricks will be better. They adapt a certain way. That's why when I am doing a surgery, my staff nurse will be giving a comment, my junior doctors will be comment. Many of the visitors will say, hey, the staff suggesting to you, he's such a big man. I know what it is. Their mind is something like a given certain idea, then they will. So that's why, everybody is important. Videoscopic, no? Everybody looking at, everybody will be commenting. Some people afraid to say, if you given a liberty, they will comment. We should know which is the comment. Every comment you need not take. Best things you have done in your practice. Yeah.
Sir, I want to make a small comment. In our country, like if you want to do many laparoscopic surgeries, sometimes in our transit system doesn't allow, sir. Sometimes, we have a general surgeon who has an upper GI interest. In 4 years' time, that person will be going to another center, and the new person will be coming will be a colorectal interest or sometimes thyroid interest. So therefore, the subsequent development has altered significantly. But but that system is there to safeguard the seniority, and the transit system, transparent marking systems are very clear. So that I think this system also should run. But within that system, if we kind of way to find expert surgeon, like then you have a esophagogastric surgery, there's a masterclass, and you give a certificate of degree or something for them. If we find a way to okay, these are the people who are upper GI, who does the maximum number of upper GI cases, special cases like paraesophageal hernias. So we identify few mentors. And if we identify that kind of mentors, we can, tell the trainees that you go to this center and learn this day, this surgery they will be performing this surgery. Is that the way you develop your system in your country? So we can get an example and we can implement in our system. SLAMADS, I think, can get the initiative within the College of Surgeons to do that also.
Yeah, very important is this. Everybody shift to Europe. If you go, most residents finishing it, they will going. Then again, they have to depend on the juniors doing it. Very difficult to practice. But it is my own, I know the difficulty is going to come, and my own establishment. So I could do it, my team development, for example. Initially, like me, every surgeon doing everything. Now I know, okay, he looks good, and accordingly I'll push them, train them. So now my hospital was the first hospital in India to have specialties in all. Bariatric surgeon only will do bariatric, and upper GI will do upper GI only. Basic, of course, everybody will do. And that is the reason, now Sadi here is taken over upper GI as a lead surgeon. Under him, there are 4 surgeons working different way. Even 1 or 2 going. But apart from the, we have trainees will be, that they will be going. But these consultants, and we have to look after them. So government also should look at that, they posting like this and developing it. After us, Tata now, they are also making specialties, and they realize the very important of this. But look at Western countries, still more, There, 2010, there was a symposium on cardia, esophageal cardia. One surgeon came and said, I'm a esophageal surgeon, I don't know why I was called to this symposium. The other guy says, I'm a gastric surgeon, I don't know why I was called. So cardia became a specialty, single portion. So this is where. And some surgeon doing it all laparoscopy everywhere, now he is announcing it, I do only fistula. Because the number of surgery he saw, that remuneration he got, now he became an international center for only fistula. After this is where people realize how to go about it. So I think it takes time to settle, but training more important, and always keep in different centers, visiting it makes more important now. So I'm very happy about this here. It is always going in. And about any comment?
Bhavanta, I just want to make one comment. Those days when we used to do some major surgery, which I have not done for 10 days, maybe 1 month, we had a Rob and Smith book, the Atlas. We used to read that previous night twice, thrice. Mentally you do that operation by reading it. Then you go and do it.
Yeah.
And that is the way we kept the complication less. Now you're in a different. This era is one of the best for surgeons because it's all in the video. You watch the video 3-4 times and you are mentally done that. Next day you can do it probably better than that video guy.
This is the second thing. The Atlas was there, diagram. Now what we realized, okay, different surgeon, different way doing it, and that many of the Western people started selling, training as a business, and CD is also business. Then I felt, no, that is, education should not be business. So every conference, anybody comes, we give a CD as a compliment. That time CD, then DVD. Now, of course, a very simple way I can give it. And if 1,000 attending, 1,000 surgeons, I will keep it 1,000. I will give them compliment, free. Let them see the CD repeatedly, so they will do. It helped them a lot. And subsequently, DVD came also. Slowly, we add a little more references, then it is guidance. So now, digital world, very easily you can manipulate the learning process. You can do that. Okay, now.
I think we'll conclude this session, sir. We'll have some tea and then come back and start the next session. Thank you very much.
Next session, what we'll do,
Yeah.
and maybe not a short, and sometime if you want to discuss something live, the Varghese, Tamanas, they used to interact directly, question answer. If 10 minutes, 15 minutes, anybody wanted to, or floor ask questions, said, subject wise, anything, other than the subject also, anything, and can have something we can have.
Yeah.
Okay, thank you.
Thank you. Thank you.
I thank, very nice, I could not give any compliment, but I thank you very much.
Thank you, sir.
What's that? They copy பண்ணிட்டியா?
Okay.